Should I share my screen?
Yeah, you can share your screen. So we are live now. We'll start. 1 second. Okay, so good evening, everyone. Today we have with us Dr. Abhinav from ICMR. He's gonna give his talk on multi-morbidity insights from India. So welcome, Dr. Abhinav, and over to you.
Thank you so much, Navya. Good evening, everyone. I'm Abhinav, and I work as Research Officer in Health Technology Assessment in India at ICMR Regional Medical Research Center, Bhubaneswar. And currently, I have been selected to pursue a fully funded PhD at University of Leicester, UK, and that I'll be joining from the January session. And my PhD and most of my work has been around multimorbidity. So let us start with multimorbidity insights from India. Multimorbidity is defined as the coexistence of two or more long-term conditions in an individual without defining an index disease. So these two or more chronic conditions or long-term conditions can encompass a non-communicable disease such as hypertension or diabetes. It could be a mental illness of long-term nature such as depression, or an infectious disease also such as tuberculosis or HIV. So when we say what is multimorbidity, we just not think about the conditions, non-communicable diseases. It could be a non-communicable disease or a mental illness or an infectious disease of long duration also. So often it is seen that multimorbidity is interchangeably used with comorbidity. So let us try to understand what multimorbidity is and what comorbidity is. When we talk about multimorbidity, it is co-occurring of long-term conditions which may or may not be related in a given patient. Say, for example, a patient has hypertension and diabetes. So these are two different conditions. So since we have the conditions, two conditions, it would be multimorbidity. But when we talk about comorbidity, it is always that one index condition or index disease has to be there, which is the focus of interest. And based on that index condition, other additional conditions may exist or may develop during the clinical course of having that index condition. So why we are talking about multimorbidity today, and especially in Indian context? So evidence suggests that multimorbidity is quite prevalent in LMICs also, low and middle income countries also, although initially it was thought that since the high income countries are now have aging population, so maybe multimorbidity is quite higher among high income countries, but it is not the fact. The fact is that even low and middle income countries such as India have equal prevalence of multimorbidity, and this is being seen because of the epidemiological and demographic transition along with socio-economic development in LMICs. So now we are seeing that our population is also uh, getting to towards the aging population, and additionally we are we have a shift in the epidemiology of the diseases also, as earlier we had an increase in the infectious diseases, but now slowly and gradually we are having a higher burden of non-communicable diseases. Then a systematic review and meta-analysis suggests the pooled prevalence of multimorbidity in LMICs is around 36.4%, which is almost equivalent to high income countries. And similar to other LMICs, multimorbidity has become a norm in India. So multimorbidity in India. Evidence on multimorbidity in India is very scattered, with studies either done in small populations or small sample sizes or in particular regions or cities. So we do not have a national level estimates, although few of the secondary data such as LASI, longitudinal aging study in India, and SAGE, WHO SAGE, which is also known as World Health Survey, have been used to extrapolate the multimorbidity in India. But those studies, again, see, the main purpose of those studies is not to measure multimorbidity, but then the conditions which have been estimated in those surveys have been used to extrapolate multimorbidity. And based on one of the my own meta-analysis, systematic review and meta-analysis, the pool prevalence of multimorbidity in India is around 20%, but it is in unpublished data. And we have already gone through a series of revisions in Journal of Multimorbidity and Comorbidity, and now it is in the stage of minor revision, so most probably it will be published. Then let's talk about emergence of multimorbidity research in India. We One of the studies was done in 2015. It was a systematic review which kind of landscaped all the epidemiological studies on multimorbidity in South Asia. And that systematic review found that 11 studies were there in India, which were not specifically on multimorbidity. A few were there, but a few were had considered two or more conditions. So based on that kind of studies, we had received only 11 studies. So it showed that there is absence of primary care based studies, which really revealed a significant knowledge gap, and no uniform measure of or definition of multimorbidity was there. So this highlighted the need to first develop multimorbidity measurement tool in India. Then again, a study published in 2016 shows that how a tool was developed in India. This tool is known as Multimorbidity Assessment Questionnaire for Primary Care, and it was developed by Sangamitra Pati et al. And this tool comprises of 22 chronic conditions, which is based on these conditions are selected based on iterative process, and it also measures the severity of these conditions. Then healthcare utilization, health related quality of life, and obviously socio-demographic characteristics are also there. So this tool is widely used tool. Its name suggests primary care, but it has been validated for community-based surveys also. And this is widely used not only in India, but also in countries such as Ethiopia, Pakistan, and a lot of African countries. So now let us talk about multimorbidity in primary care. This was one of the major gaps which was identified by Pati et al. Through their systematic review in India. And then they carried out this study, which was published in 2015. And this was the first ever study on multimorbidity in primary care in India. See why multimorbidity is important for primary care. We talked about two different terms, multimorbidity and comorbidity. While multimorbidity focuses on the number of conditions, comorbidity has an index condition. So multimorbidity is more important in primary care, because in primary care we'll have a general physician, and the general physician is supposed to screen, supposed to give the basic treatment, and if required, then referral has to be done. So multimorbidity term is very much important at the primary care, while comorbidity is important at the tertiary care or maybe specialist level, where, for example, say a person has diabetes, he goes to the diabetologist or to some specialist doctor, and then with respect to diabetes, he develops other conditions, and that could be taken care of. So multimorbidity is a challenge for patients and healthcare also, because a lot of healthcare utilization will be there, frequent visits to doctor, frequent lab investigations, continuous medicine is required. So moreover, primary care is the first and foremost and major healthcare provider for most of these patients, because our India is mainly still a rural based country. So most of these rural people, or even in the cities, the first and foremost point of contact will be primary care, so both at the level of public as well as private practice. And this also acts as an interface between community and healthcare system. As I told you, that this will be the first point of contact. So this is the best suitable place where multimorbidity could be diagnosed, prevented, as well as treated, managed. So this study done by Pati et al. In 2015 identified that the prevalence of multimorbidity was around 28.3% at the primary care level, and which ranged between 5.8% to 44.4%. And the age group which they took was 18 years and above. And this result is almost similar to the high and middle income countries. So why I'm telling that this is similar to high and middle income countries, that this is a very burning issue which needs to be taken care at the policy level in India also. Then next we talk about multimorbidity. in community settings. So one of the studies, recent studies published in 2020 by JS Shatri uh, in Odisha, identified that the overall prevalence of multimorbidity in community was 48.8%, and it was higher among females. So they also identified dyads and triads. Dyads are where the patient has only two conditions, whereas triads are where patient has three conditions. Now, this is one of my own paper. We had done this multimorbidity among midlife women. So females outlive men in most of the world according to the life expectancies. So, and especially during the midlife period, women transit towards menopause, which along with they have a natural series of natural physiological changes such as menopause, which leads to osteoporosis, depression, and other such conditions. So that is the reason why we wanted to estimate multimorbidity among midlife women, and we observed that the prevalence of multimorbidity was around 30% among them. And we also observed that the health related quality of life indicators, which we took as self rated health, work limiting health conditions, mobility, and activities of daily living, all these conditions were compromised. Next is multimorbidity among urban poor. So this is also again one of my own papers, and urban poor is a such a community faces disparities or inequities, which could be with respect to the access to healthcare services. As they migrate to a newer place, they have um, problems, or you can say compromised living situations with lack of wash facilities, and they face challenge of impoverishment. They may face challenge of impoverishment due to long-term conditions, because as I already told that continuous medications, continuous visits to doctor and everything is required in long-term conditions. This may impact the universal health coverage which we are aiming to. And also amongst these vulnerable groups, there is a inverse care law, which is applicable not only for multimorbidity, but for other conditions also, or other diseases also. Inverse care law suggests that in areas of compromised socioeconomic status or lower socioeconomic status, the physicians are also burned out, as they have a higher number of patients to see, and due to which they do not focus on each and every patient, or do not give the required amount of time to each and every patient, and this can also cause disparities in access to healthcare. So overall prevalence of multimorbidity was observed to be around 45% among urban poor, and this is based on the LASI data, which is among the age group of more than 45 years. So here, whenever I'm talking about the prevalence of multimorbidity, the age group also is very important. So that is why I'm telling the age group, because we saw this study by Pati et al. In the primary care, it was amongst 18 plus population, the prevalence was 28% around. So, but here it is almost 45% because the age group is higher. So higher the age group or aging population, we expect people to have more number of conditions. Then one important finding which we had amongst urban poor is that those who had health insurance were at a higher risk of having multimorbidity. So this is very important. Why? Because if it suggests that those who had health insurance, they were getting better access to healthcare, and that is why, since this is data is based on LASI, longitudinal aging study in India, it's a self-reported data, so they were able to report more multimorbidity or more number of conditions. So health insurance schemes such as Ayushman Bharat is very important to have a protection for these vulnerable groups. And we also observe that for each additional condition, the out-of-pocket expenditure on healthcare increased and self-rated health decreased among these particular individuals. Next is multimorbidity among tribal people. So this is also my own study, and it is based on evidence from SAGE data, study on global aging and adult health, which is done by WHO. in 6 countries or 6 low and middle income countries of the world. So based on the Indian data, we observed that we tried to extrapolate multimorbidity among tribal people. What again then tribal people are important with respect to multimorbidity is that there were no studies um, on multimorbidity among tribals, and tribal people comprise of almost 8.6% of the Indian population. They have distinct socio-cultural beliefs with overuse of alcohol, tobacco, etc. And recently we have observed that there is a changing lifestyle among tribal people also. And moreover, similar to urban poor, these people are also a vulnerable group, and if they are not covered, or if they are not treated properly, then our universal health coverage will be impacted. So the overall prevalence of multimorbidity among tribals was observed to be around 22.6%, which is roughly 23%. And here again, interestingly, we saw that affluent groups had a higher risk of multimorbidity. So similar to what we observed in the urban poor, that those who had health insurance had a higher risk of multimorbidity, here affluent groups had a higher risk of multimorbidity, which suggests that those affluent groups were able to pay, were able to seek care, hence they knew of their status of the conditions or diseases, and they were able to report, since this is also based on a secondary data and it is self-reported data. Now there is another term known as complex multimorbidity. So a lot of a second school of thought suggests that multimorbidity may be important for primary care because but it is a raw data. It suggests only the total number of conditions, that is two or more conditions, which could be anything, could be a heart condition or a simple hypertension, which could be, hypertension could be controlled, but if some condition is there which cannot be controlled, so it needs different kind of care. So that is why this term emerged. This is a complex multimorbidity, which is referred to as the co-occurrence of three or more chronic illnesses across more than two body systems. So here they are also considering the body systems. So for example, the cardiovascular system is supposed to be one of the body system, and the respiratory system is supposed to be the another body system. So more than two body systems, that is three body systems and three chronic conditions should be there to say that it is a complex multimorbidity. And this is mainly to identify persons in need of additional medical support, and these people may be vulnerable to emergency care also. So we need to have a data on these people who need emergency care, who might need emergency care or additional medical support. And this is again my own paper, and this is the first and only paper on complex multimorbidity in India till now. And we observed that the overall prevalence of complex multimorbidity in India is around 34.5%. And we saw that there is a higher utilization of inpatient services. So see again, since it is more than two body systems and three chronic illnesses, so we observed that the inpatient services was higher among these individuals, and obviously the out-of-pocket expenditure was also high. Then a new concept has been introduced, which is family level multimorbidity. So this is based on the fact that most of the evidence in the entire world globally on multimorbidity is drawn based on the individual level assessment. Whatever studies we saw till now were based on the individual level assessment. For example, I have diabetes and hypertension, so I will be said to have multimorbidity. But the problem is that within the family, we have shared risk factors. For example, we eat food, especially in Indian context where we have extended families. So the food cooked will have similar amount of salt, which is one of the risk factors for multimorbidity, or physical activity, sedentary lifestyle, all these kind of risk factors will be common for the entire family, more or less. So then should we look at the only the individuals, or should we assess the total household or family? So this new term was coined or introduced by us, Sangamitrapati et al. And we defined family level multimorbidity as two or more members of family having multimorbidity. So why this is important? Because now here two different terms come, which few of us will be aware also: concordant and discordant conditions. If the conditions are similar among the family members, then the kind of precautions or uh, kind of treatment availment and everything becomes easy. But if these things are different, if the conditions are different, then it is difficult to maintain. For example, say if husband and wife has hypertension, both of them have hypertension, so they could in whole they can cook the food without salt, or they can add less amount of salt. But especially within the Indian household system, if husband has hypertension and wife doesn't has, so most of the time it would be that the husband's food, whatever husband eat, the same food wife will also eat. But if it is vice versa, if the wife has hypertension, the husband doesn't has hypertension, then the problem will arise. Then more or less the wife will have to adjust with the husband's thing. So these dynamics, although we are talking about all these dynamics, and it seems that these may be the stories, but it is the harsh reality. And we observed the coming to the prevalence, we observed the prevalence was quite very high. It was around 44.5% among the families, that is two or more members of a family or household having multimorbidity. Within the same paper, we also looked at the conjugal multimorbidity. Conjugal multimorbidity is a uh, is a term which has been used earlier also, so it is not a new term, where both the partners have multimorbidity. The story which I was just telling about the husband and wife. So although these husband and wife or the partners are genetically unrelated, similar environmental and other risk factors, they share these similar environmental and other risk factors. So we observed that among none of the partners, 25.2% did not had multimorbidity. 33.3% amongst 33.3%, one of the partner had multimorbidity, and 41.5% partners, both of the partners had multimorbidity. Then sibling multimorbidity. Sibling multimorbidity can be said as two or more of the siblings living in the same household have multimorbidity. Now, these individuals are genetically related and they share environmental and other risk factors also. So we observed that 25.5% of these siblings did not had multimorbidity within the same household. 32.8% had the one of the sibling had multimorbidity, and amongst 41.6%, we observed that two or more siblings living in the same household had multimorbidity. Next is intergenerational multimorbidity. Sorry, this is for this typo error, sibling multimorbidity, it should be intergenerational. So two or more generations living in the same household have multimorbidity, and again they are genetically, they may be genetically related and they share similar risk factors. So we considered up to 4 generations as provided in the data. So amongst 17.7%, none of the generations had multimorbidity. Amongst 36.2%, at least one of the generation had multimorbidity, and amongst 46.1%, two or more of the generations had multimorbidity. So all these suggests that within the household or family, the shared risk factors should be altered so as to prevent multimorbidity. And this also suggests that we need to look at the family as a whole rather than only looking at the individual for assessing multimorbidity. Next is uh, this is one of my recent papers where we looked at the childhood disadvantages and multimorbidity. So amongst LMICs, we could identify only one of the paper, one of the study was from China, had looked at this, and within India, there was no study which looked at childhood disadvantages and multimorbidity. So life course epidemiology suggests that adverse events in early life contribute to compromised health in adulthood. And There is lack of evidence on early life events and social factors on the development of multimorbidity among adults. So here we observed that participants who perceived their childhood health to be poor and missed school for a month or more due to illness had the higher chance of having multimorbidity. So basically, these individuals were asked about their status during childhood. These are all adult individuals aged 50 years and above, and they were asked at the time of data collection that how they perceive their childhood health, and those who said that their childhood health was poor, or in a second question, those who affirmed that they missed school for a month or more due to some illness, those particular individuals had a higher chance of having multimorbidity in their adulthood or at present. So this again suggests that even educational disadvantages or childhood health should be properly taken care of, because the childhood or early life events can contribute to the compromised health status in adulthood. Next is oral health and multimorbidity. I am a dentist. So this was one of the very interesting studies which we had done. Everyone knows that oral health is related to overall health, but seldom oral health is given importance, especially in context to LMICs in India. There are common risk factors for oral health as well as physical health, such as frequent snacking, dietary intake, and etc. But still, oral health is neglected. And also, it is said that your mouth is the mirror to your inner body. So if oral health is found out to be compromised, then you have a higher chances of compromised overall health also. But this is seldom given importance in India. So moreover, it is also important because now we have the concept of health and wellness centers in India, which are the uh, kind of primary health centers which have been um, kind of given uh, their it has been broadened. So within those primary health cares or health and wellness centers, now dental treatment is also available. So interprofessional coordination is required, so that both oral health as well as physical health could be equally taken care of. And we observed that those who had oral morbidities, they also had a higher chance of having physical morbidities in this study. Next is multimorbidity and risk of falls. So aging and multimorbidity increase the risk of falls among older adults. And again, why falls is important, because fall may lead to um, if once fall is there, so obviously there will be physical problems, but that also leads to fear of falls in future, and that could lead to sedentary lifestyle among elderly, and that could again, it's a vicious cycle of again getting into more physical morbidities. So that is why we investigated this, and we found out that multimorbidity is an important predictor of fall significant, and this was observed significantly among females and rural residents. Outcomes of multimorbidity. So this is all what we talked about: the prevalence, importance of multimorbidity, and how the multimorbidity research evolved in India. But what are the outcomes of multimorbidity, and why multimorbidity is important, and what it could lead to? So multimorbidity could lead to increased healthcare utilization, as frequent visits to doctor is required, frequent visits to physician, use of long-term use of medicines, then continuous laboratory investigations is required. So your healthcare utilization increases, and since your healthcare utilization increases, you are more dependent on caretakers or caregivers for getting these healthcare, especially because multimorbidity is more oftenly seen amongst aging population. Then lowered physical functioning is there, compromised quality of life, health related quality of life is always compromised. Then psychological distress will be there, higher healthcare expenditure on both inpatient services as well as outpatient services, and it can also lead to elderly abuse. Evidence suggests that multimorbidity may lead to elderly abuse, as these elderly who require frequent visits to doctor or frequent management of disease or conditions, they may be neglected. We talked about falls already. And polypharmacy, that is polypharmacy is defined as five or more drugs taken at a time. So with the increase of conditions or with additional chronic conditions, the risk of polypharmacy also increases amongst multimorbid patients. So this was an overview of what multimorbidity is, how multimorbidity research has taken place in India. But still, I would just say that whatever I have shown is a tip of the iceberg, and not much has been done in India for multimorbidity, and it is very much required, especially to strengthen our primary care. So, in conclusion, multimorbidity is common in India, and it is common amongst with increase in age. It is not just an older adults issue, as we have seen in several studies with age group 18 plus, that even those people have multimorbidity. And also in the latest guidelines or the policy, um, it is suggested that all individuals 30 years of age should be screened for non-communicable diseases. So even government considers that it is not just an older issue, but prevention is always should always be at a earlier age. Then we see that higher prevalences of multimorbidities among females and across all adult life stages. Then certain combinations we talked about dyads and triads. So those combinations within multimorbidity impose higher severity for patients, and we need to identify those most common severe clusters. The healthcare visits and medications is significantly higher in multimorbidity, and especially for vulnerable people, if we want to achieve universal health coverage, they need to be given some sort of either the access to health and wellness centers or primary health care centers, or some kind of insurance scheme such as Ayushman Bharat. Then health related quality of life is significantly impaired, and besides the number of conditions, severity and type of chronic conditions also influence the health related quality of life. So what are the implications? We have already talked about the implications, but let us again jot it down. Primary care should be built along with the capacity of the primary care providers. Then we should address the high risk and high needs patients. We should identify and address the needs of high risk patients, and focus on early detection and management of single condition should be there, so that multimorbidity does not comes into picture only. And very importantly, digital patient records should be there so that we can follow the trajectory of these patients. And national health programs should harmonize guidelines for integrated patient management. Women's health beyond reproductive well-being is very important, as we see that most of the programs which focus on women are confined to their maternal health, or up to the age of their 49 or 50 years, which is the with that it is they do not consider women's health across the menopausal age. So that is very important, that women's health beyond reproductive well-being should also be considered. And MACPC tool, which has been validated in India, can be used in different healthcare settings. So priority for primary care policy, practice and research. Multimorbidity is a priority for primary care policy, practice and research. Thank you. Over to you, Navya.
Thank you, Dr. Abhinav. Over. So I would like to request everyone, if anybody have any question, we can interact or something before I say something.
Yeah, hi, Navya.
Yes, Dr. Rupashri.
Thank you so much, Abhinav. This was a wonderful presentation, especially you've given us data related to how best you have taken the research protocol. I really appreciate you for this entire narration. My small question, I just was thinking as I went through your presentation, when you said about multimorbidity aspects, whether this acute deterioration protocols have been considered in taking multimorbidity into consideration? This is my first question. Second question is related to six sepsis criteria or sepsis scoring, because multimorbidity means when you are involving multi-system. So has this sepsis care bundle approach or anything, has it been considered in your area? That is, I was referring to the new score and also the pediatric scoring system. So there is a separate protocol in that. Has it been considered or has it been totally eliminated in this point? Then the second thing I wanted to ask is related to this cardiac care. When we understand you have considered respiratory system and also the cardiovascular. When cardiovascular system itself is the second largest areas of cardiac death cases in the entire world, whether exclusively that data is taken or is it along with the comorbidities is considered. Now, in India, we don't have something called as a fall registry, whereas in USA, anyway, UK, you are coming to listers. So I wanted to just say fall registry is there, whether it is adult or people related to that. So are you considering the comorbidities related to fall in those lines? So this is also one of my question. Now, the last question, the fourth question, is related to when you say comorbidities, are you considering the road traffic accidents, RTA, or from relation to road to you're going to A&E and then to rehab, whether these are also considered as comorbidities? So this is my question. I hope you can answer. Thank you so much.
Thank you so much, Rupashri ma'am. So first of all, I'll answer your last question because that is very straightforward. Yes, RTA is considered while considering multimorbidity. Then your first question, acute conditions. So actually, when this whole definition of multimorbidity or whole
Acute
concept of
deterioration. Acute deterioration before
deterioration.
one step before sepsis.
Yes, yes. So actually, when this entire concept of multimorbidity was being considered, only the long-term conditions were taken care of or were included in the multimorbidity concept. But recently, I have been seeing, and especially with studies from UK, and studies which particularly which have been done from the data from UK Biobank, they have been considering acute conditions as well as the acute sepsis also, which you are talking about. So yes, I'll say it is definitely there, but with respect to India, I have not seen any such study, because maybe in India it is a very newer concept, so maybe that would be one of the reasons. Then one of the questions was about the six sepsis bundle or something like that. So I'll just say that I'm not much sure of it, and I'll definitely look at it and I'll put it in the group.
Sure. I was talking about the new scoring and also the pediatric scoring system for sepsis criteria. In UK, we do use this sepsis criteria in very much in thing. My middle third question was related to fall registry.
Yes, so we do not have fall registry in India, and in total we have six centers in India which cater to the fall needs of the people. So that is again one of the very important question which you have raised, that should be considered in India also. And with respect to fall, yes, fall is one of the chronic condition because it also leads to various other chronic conditions also. So yes, fall is considered within the ambit of multimorbidity.
Thank you so much. It was great interacting with you. You answered all my questions. Yes, as policy matter or as at the level of public health policy strategizing. We don't have a fall registry, we don't have sepsis areas, and also related to acute deterioration protocols. The hospital has to implement these protocols, and we need to understand how it is being time tested from the in our hospital or in healthcare where I do work for NHS. We have these systems in place, and we do have task driven approach, and we do have timelines to handle all this, and these data have been collected, compiled, collated, and then finally it is being provided at the national level where I do the audit of these sectors. So I just thought I would add up. Abhinav, it's a great presentation, really loved and enjoyed your presentation. Thank you so much.
Thank you so much, ma'am.
Yes, please, Dr. Zoha.
Okay. Hi, Abhinav. It was really very comprehensive and topic which so far I don't think I have really explored much. So seeing the data, it seems like everybody is having comorbidity, right? Not just the elderly, but the females across all spans of life. And with some research from China also roping in the children, and then ma'am talking about the various scorings, it seems like and the rich and the poor and the tribal, everybody seems to be getting comorbidity, uh, or rather multimorbidity. I mean, the data in that sense is scary. So my point is like, surely there is a dearth of research in the Indian context, uh, but since it's such a problem where it is touching upon almost every age group. So, are there any recommendations or any policy statements in the Indian context where you see this getting implemented? Or, I mean, um, what are the takeaways for the policy people for on these, or people who are working on this, or some of the gaps in the research which are present, which researchers can explore, or what is your take on that?
Thank you, Dr. Zuma. So actually, I'll just tell you that particularly when we talk about multimorbidity, there are no policies related to that in India, but government is working towards it, as it is one of the non-communicable diseases, or the emergence of long-term conditions is one of the priority areas in our National Health Policy 2017. And recently in that line, earlier we used to have NPCDCS program where the non-communicable diseases, a few of the non-communicable diseases were focused. But recently, very recently, with just 3 or 4 months ago, that program has been renamed as National NCD program. And within the ambit of the National NCD programs, a lot of additional conditions have been added so that those conditions could be taken care of. But when we talk about dealing with multimorbidity as such, or looking at the multimorbidity at primary care level, so there are no policies as such. But within UK, there is particularly a policy for multimorbidity.
Sorry to
I
interrupt.
have a Yes, ma'am. You wanted to add something?
Yes, I wanted to add, Abhinav, there are policy matters related to multimorbidity. Let me add, in Indian context, we have stroke registry. See, any multimorbidity after when the complication has arisen and doing things, India has stroke registry from many years, almost from 10 years. And also related to multimorbidity, diabetics has, a gamut of national level registry where these areas has been considered. We have diabetic registry for pediatric and adult. Also we have also hypertension registry. So data is there, and it is up to us to explore. So let me give, in Indian context, there are registries, and policy matter is already in place, and it is being implemented also. Let us understand the outcomes, and in this areas we have even not only the registry, the government has done policies, they have done wonderful work. So I, being an Indian, I should be proud of saying this. I hope, Abhinav, maybe we are not aware about it. Getting the awareness is the most important thing. So just wanted to add.
And it also might be that the body of work or the implementation, the scale of the implementation might not be that much uh, of a stature that it's catching the eyes of the researchers, or probably it is getting missed. That can also be one of the things. Ma'am, do you think so?
I am aware about it from 2016, even though I was still a student. So I don't know about
No,
others.
no, I'm asked.
And
No, no.
second thing is,
See,
yeah,
my point.
regarding the, no, let us not take it personally. Don't take it, Zoha, in that point. I want to just add the knowledge aspect here. See, it is implemented, and the thing is the outcomes are already there, but as researcher, like, we don't have many Abhinavs who can publish it, but data as such we are able to provide it from the ground level. So this is what I have understood. Even diabetic, there are a lot of projects which have undergone and they have been undertaken. Only the publication aspects as a manuscript or in the international area, it is not done. But we do have quite a substantiated amount of data which is being collected and compiled. Only that it might not be validated or it might not be published. So that
Yeah,
is what
that
I
is what
was
I'm.
trying to
Yeah, actually,
provide.
probably you misunderstood what I was saying, ma'am. I was saying the
No
policy is there.
misunderstanding. Everything is
The
fine.
policy.
So Joha,
Yeah,
thank you so much.
the policy is there. The implementation stature, I mean, it must be or the departments are working in silos, like it's happening in One Health. The departments are there, the policy statements are there. It's just that when it is coming to the implementation, or when it is coming to the collaboration, or when it is coming to the point where it could have garnered greater support from the community, it kind of falls short. That can be just one of the reasons why we might have missed, or why Abhinav might have missed. That is just a point ma'am stated. So nothing personal on that point. Abhinav, my point was, one of the questions which I wanted to ask is like, in the last slide you had mentioned that one of the recommendations can be like focusing on one condition at a time, so that I think that you had mentioned in the last slide.
Yes, yes.
So one of the points which I was just thinking, like, if somebody is having hypertension, and then later another condition adds on, like the heart is getting weakened, or a cardiac issue is adding on, and then maybe down the line the renal is also going. So are these all not just the manifestations of a single condition which was not probably treated or got addressed, or probably it got worsened to the point like other organs have started getting involved into the picture. So is it really possible? I mean, I was just thinking.
Yes, so actually, that is what that line suggested, that if that's whenever that first condition is develops within an individual, if that condition is treated, if say for example hypertension, so if hypertension is controlled, then maybe we'll not be shifting to the newer conditions as you mentioned. So that is what I meant with that statement, that if the first condition is identified early, is diagnosed early and treated well and adequately, then will not be moving towards multimorbidity only. And the
It might
second,
be one of the reasons, but I would like to cut it short in this point. Each disease and each has got its own comorbidities, and the etiological factors of each disease also varies.
yes,
So
ma'am.
skin disease need not have hypertension. So I
Yes,
don't understand it that way. Or a dental, tooth might not have a foot injury. So it need not be correlating. So the etiology of each disease has got its own specification, and those are the variations of the disease component.
no, I agree with you, ma'am. That is why the concept of multimorbidity is distinct from comorbidity. What Zuha ma'am is talking about is more of a comorbidity. So, but still, when we are talking about
Yes.
multimorbidity, if whatever condition is seen, it should be treated specifically so that it at least stops or subsides or remains within the limit and does not, lead to other conditions or other risk factors. And one more thing I just want to add, with respect to the guidelines or the registries. Yes, I totally agree with Rupashri ma'am that we do have guidelines or we do have registries, but those again are for individual conditions. For example, we have a registry for stroke, we have something for diabetes, or the guidelines, or even the management guidelines, which is given to a primary care physician. But if a patient comes for, say, hypertension, at the primary care level, he or she is treated only for hypertension, and they are not even asked for other risk factors, family history, on contrary to what happens in the high income countries. And there we lose the chance to diagnose early detection of the additional conditions. So that is one of the major shortfalls in our guidelines. Whereas the guidelines which I was talking about in UK, NICE guidelines, it is particularly for multimorbidity management, NICE guidelines. So those kind of guidelines need to be introduced in India. And also, if not the guidelines, I say that at the level of primary care physicians, it's within the curriculum of MBBS, those kind of treatment strategies or kind of thinking should be put in, so that the doctor just not just gives importance to the one condition, but rather in toto approach should be there.
Yes, nice guidelines is a superb guidelines. We do follow that. I would like to add one more thing, Abhinav. It is not only the doctors who needs to take the responsibility. It is a partnership. The patient
Yes.
also should take the responsibility. I would like to say they should be voluntarily taking it. The community should take it. The social enterprises, or as a society, they should be also taking the responsibility. Now, yesterday I was going through this up-to-date, literature search, which I became a trainer. So I would like to highlight. They have a separate portal exclusively for the patient side story or the patient inputs, which not from the doctor's perspective or the researcher perspective or the stakeholder. So what the patient perceives or what the patient prioritize as their health condition, they put it across, and they are able to narrate it and navigate the entire content. So that has become a wonderful aspect in up to date. If you can see it, Abhinav, you're in research, so I just thought. So such possibilities, if we can bring it up and tackle the system as a priority, and they should be also taken as a partners in the service care providing, then the onus lies on everybody. That's what I would like to put it across.
Yes, ma'am, I totally agree with you. And I'm sure that India is progressing with respect to health literacy as well as digital literacy. So once health literacy comes and digital literacy is already garnering importance, so we will surely be reaching to this point. But at this point of time, I mean, the patient is also not much aware, especially with respect to rural people, and India is mainly a rural country. So, but yes, I'm sure that very recently this will be done.
Yeah, that's the thing which we all as social researchers, we would like to see. We need to empower people, we need to empower the community, and also
Yes,
make connections, and the social actions has to be taken into consideration. I feel that is in short as a end to this thing. Thanks,
yes.
Abhinav.
Thank you
Great.
so much. Thank you so much.
Okay, thank you so much, everyone. No more question further. I guess that's all. We'll wrap up for today. Thank you so much, everyone, for joining. Bye.
Thank you. Bye.